Hey, it's Lieutenant Ryan Mitchell with Pinellas Park Fire Department. I'm teaching from Pinellas County CME. I've got my hands in the video. I know you guys liked that before, so I'm going to keep them here. We're going to get it done. We're talking about needle thoracostomy, so let's run through some pitfalls, some tips of the trade, tricks of the trade, some things I've learned from you, and some things I've learned doing it in the field. So let's talk about it. First off, let's work through our anatomy. Right here, we've got our clavicle, right? And the first rib actually sits just under, kind of just below the clavicle. So let's start there. As you're counting off your landmarks, realize that the clavicle and the first rib are kind of housed together. So count that as your number one. We've got 1, 2, 3 ribs, right? Above the third rib is the second intercostal space. That first intercostal space falls below the first rib. So first rib clavicle, first intercostal space, second intercostal space. There's a little bit of a tip I can give you, a little trick, if you can find the angle of Louis, especially for people that have a lot of weight on them, they're carrying a little bit of extra meat. The clavicle usually isn't a fatty part of the body, so if you can find the clavicle, find the angle of Louis, named after a French physician, for everybody who wants to know, angle of Louis, that should be consistent with the second rib. Right? The second rib works out, go right below that, that'll give you your second intercostal space, and that's the mid-clavicular line. Now, that's what we've been training on for most of the time. There is a change in PHTLS, so we're going to divert to the anterior axillary site, okay? That's going to be our preferred site moving forward. You can use this site, but the preferred site is the anterior axillary site, which is going to run right along the anterior line here, and it's going to cut right about there, the anterior axillary line. It's just past the nipple, and that's going to be our preferred site, fourth or fifth intercostal space. How do we count that down? If I work that second rib out, my angle of Louis is right about here. If I work that second rib out, it's right about the axillary fossa here, okay? 1, 2, 3, 4 ribs. Right here, fourth rib. Fourth intercostal space, fifth intercostal space. That's going to be your anterior axillary site. What we're trying to do is avoid things like the liver, right? The spleen, the kidneys, all of these have been tapped in the county, so we want to kind of move away from that. So talking about some pitfalls here. When you use the mid-clavicular site, here's where we're running into some issues. I'm going to bring old Chesty McChester in here that is conveniently missing shoulders. It's not that it's a bad tool, but if you don't understand the tool, you don't understand the training implement, then you're going to default to this in the field. So what we're seeing is people will count out mid-clavicular. They'll start at the middle here, and they'll stop here, mid-clavicular. They'll stop here, mid-clavicular. And look at that. Look at where the holes are on this mannequin, right? That's mid-clavicular. Air quotes mid-clavicular because it ain't mid-clavicular. This is mid-clavicular. Chesty, out. This is mid-clavicular. Start here, go to where the clavicle ends, connecting to the scapula. That's where the clavicle ends. So if I count from there, work mid-clavicular, I end up in a spot that is conveniently not located in the pericardial sac where the heart is housed. I don't want that. If I default to my training with Chesty McChester with no shoulders, I go mid-clavicular, I stop here, leave off 2 inches of the clavicle, go mid-clavicular, count down 1 rib, 2 rib, second intercostal space, and I'm tapping the heart. You and I probably are on the same page that that's a bad thing, and I don't want to do that. So, I don't want to cause iatrogenic injury with my 10 gauge, 3 inch, 3.25 inch air release system, aka my chest dart needle thoracostomy tool here. I don't want to cause iatrogenic injury, which is injury that we cause to the patient, right? So if I count off the right landmark for a mid-clavicular site, I'll end up not tapping the heart. But again, we're doing PHTLS and we're going to shift to try and get away from doing this little number here and hit the anterior axillary site just past the nipple. So that's going to be our site here. Now a few things to talk about. Under each rib, we've got a nerve artery vein, nav. As we go for the chest, there's something that needs to be explained, and I'll tell you, I learned it from one of you guys while I was teaching a couple of years ago. So I would come up and I would say, I'm going to go 90 degrees to the plane of my patient, right? So I'm just going to dart him. I'm just going to come in here, 90 degrees, and tap him. What's the problem with that? If I come in straight 90 degrees to the patient, I'm likely going to tap nerve artery vein that's running under the ribs. I don't want to do that. It's 90 degrees to the plane of the chest. That actually rotates this a little bit like that, right? So if I come in like that, you can see how I'll probably miss the nerve artery vein that's running under that second rib. So putting this into practice, again, we're going to go with the plane of the chest, not a 90-degree angle to the plane of the body, right? So plane of the body is straight in. Plane of the chest, I'm going to tip it up and go with the plane 90 degrees to the plane of my chest, right? So just confirming though, we are focusing on the anterior axillary site as our preferred site. That's the new site for PHTLS, so that's what we're going to focus on. I just wanted to touch on our mid-clavicular site to make sure that we know some of the pitfalls that we may be running to based on our training implements, right? So the anterior axillary site, just to kind of talk about that real quick is, again, we don't have a shoulder here, right? But if we go mid-clavicular, so if our clavicle ends here, we go mid-clavicular, between that spot and the end of the clavicle would be our anterior axillary line. It's going to run just lateral to the nipple. It's going to run right along this space. On me, it's going to run right along here where my pec ends, right along this region here, okay? Now, conveniently, if you're a healthy, dapper-looking guy like myself, my nipples are in the general region they should be. I'm glad that I told you that, and take that information to the bank. So, my nipples are generally where they're supposed to be, so if I run that out, it's going to be the fourth rib. Everybody's anatomy is a little bit different, so if the nipple's a little bit lower, don't use that as your landmark. Use the general anatomical place where a nipple should be. Here, fourth, run out, that should be the fourth rib. If we look over here, the fourth rib is right above the fourth intercostal space. Fifth rib above the fifth intercostal space. So if you count down from that rib, 1, 2, fifth intercostal space is right here. Preferred site for the anterior axillary region of this needle thoracostomy is the fourth and fifth intercostal space on the anterior axillary site, that line that runs lateral to the nipple. So, right here, and again, being mindful that you don't tap the vasculature or the nerves that run below that superior rib, right? So, run it out, and just a point to just talk about, as the ribs roll back to the posterior region of my body, they curve up, right? So be mindful that that rib's going to be curving up, so you have to kind of take that into account when you're looking for your landmarks. Pediatrics, same deal, preferred site, and anterior axillary. As you move back to more the mid-axillary site, just be mindful the ribs are going up. And if you can't get to that stuff, look at your mid-clavicular site. You can still do it, just not as preferred. And especially in our active shooter situations, think of that, just a point to think about with your patients that may be wearing ballistic gear, like our law enforcement officers. The mid-axillary, anterior axillary site is a little more accessible. Open that up and have access to that site, right? We have two pieces of equipment that we're going to be using for this. We have our 10-gauge, 3.25-inch ARS, air release system, needle thoracostomy needle, right? It's a little bit more rigid. Some of the other ones were a little more flexible, and they go in and they wouldn't actually hold a position. So it's a little bit more rigid. I'm going to lay it down. I'm going to do this in the correct manner, contrary to maybe what I was doing in some of the earlier portions of this video. Again, catch my cap. For the pediatric, it's a 16-gauge, 1.16-inch needle for our pediatric patients. And just be mindful, this is 3.25 inches, right? In an elderly person or a person that's just super thin like myself, don't just drive this home, right? Don't cause an iatrogenic injury caused by us, the clinician, to our patient. be mindful that you don't want to just stab this right through their back. Right. We are only doing this for tension pneumothoraxes, right? Tension pneumothoraxes. Everybody said tension pneumothoraxes. We're not just darting people's chest based on a penetrating injury. I think that about does it. I hope you learned something from this. Thanks.